see you, to be here. So I'm a pediatric infectious diseases doctor. So I take care of children in the United States. Can I ask you, how many of you, can you raise your hand if you, thank you. Can you raise your hand if you work at a children's hospital or if you work with pediatric patients? Okay, good. So we have a few here. So I like taking care of children because they're cute and they're fun. So there's some differences for VAE in the definition for surveillance between adults and children. So for those of you who work with children, I'll just briefly mention some of the differences so that you know you can see the pediatric definition. I'm just going to skip through slides until I can show. Okay, so this slide will compare the adult VAE definition that they use for surveillance with adult patients versus the pediatric VAE definition that we use in children. So this will be a review of what Dr. Park just showed you. So remember, you have to have a baseline period of stability for 2 days on the ventilator before, and then you have to have 2 days of worsening lung function. And when you have that, that's called VAC, and it's the change in the FiO2 and the PEEP on the ventilator that help you identify a VAC for an adult. And then in children, instead of using the FiO2 and the PEEP, we use FiO2 and then we use the MAP, the mean airway pressure. So similar to adults, you have to have a baseline period of 2 days where you're stable on the ventilator, and then there has to be 2 days of worsening of either the FiO2 or the MAP, the mean airway pressure. And then we call that a VAC for pediatrics. And the reason that we use MAP instead of PEEP is because in children, MAP is a mean airway pressure is a better measure of lung compliance. PEEP is a setting on the ventilator that you can change if you're the ICU doctor, but MAP is a reflection of the lung compliance. And the way we use ventilators in children is a little bit different, and especially if you have children who are on high-frequency ventilators. I don't know if any of you have high-frequency ventilators at your hospital. There is no PEEP, there's only MAP. And we use those kinds of ventilators more often in children than they use in adults. So for that reason, we base the definition on MAP and FiO2 in children so that we could include all of those children on the ventilators, even if it's a high-frequency ventilator. And then you also see that the criteria, the cutoffs are a little bit different. So in children, your FiO2 has to increase by 25%, and the MAP has to go up by 4. So the numbers are just a little bit different from adults, but it's the same concept. You have a baseline period of stability, then you have 2 days of worsening based on worsening FiO2 or worsening MAP on the ventilator, and that's a VAC, a VAC. And then I'm going to show you one other slide. Oh, can I ask you to advance for me? I'm not going to go through all the details, but this is helpful, I think. So remember he showed you, Dr. Park showed you the 3 different tiers. So we have the same 3 different tiers for children with VAE. The first tier is VAC that I just told you about. And then instead of IVAC, infection-related VAC, which they use for adults that you heard about from Dr. Park, we use something called AVAC, which stands for pediatric VAC with antimicrobial use. And then inside that is the 3rd tier, which is possible VAP, just like in adults, okay? So the second tier is a little bit different for children. Instead of IVAC, we have AVAC. So in adults, remember he told you that to meet infection-related VAC, you look at the temperature, the patient's temperature and white blood cell count. In children, and you also look at whether a new antibiotic was started for at least 4 days. In children, because almost all children on a ventilator have abnormal temperatures and white blood cell counts already, we don't use temperature and white blood cell count as part of the definition. We only use the new antibiotic. So if you have a VAC and then you get started on a new antibiotic for 4 days or more, that's called an AVAC. That would meet the tier 2 definition for children. So that's a little bit different. the new antibiotic is evidence that you might have an infection. So it sort of captures the same idea that maybe you have a VAC and maybe there's some evidence of infection, okay? And then the third tier, possible VAP, PVAP, means you have an AVAC plus you have some positive test result like a positive culture that is more specific evidence that there's actually infection, okay? So it's the same idea for children, but just the definitions are slightly different. So if you work in a children's hospital or you work with pediatric patients, you would use the pediatric definitions. These definitions became official in NHSN in January of this year, January 2019. So if you search online, you can find the pediatric VAE protocol from CDC, and it has all these pediatric definitions that you can get all the details if you want them, okay? Okay, so if we can close this presentation, and then we'll go to the one about preventing VAE. No, sorry, not this one. Not that one. Oh, we got this one. Yes, this one. Okay, good. Perfect. Okay, so we're going to concentrate now for the rest of the session on prevention. So we talked a little bit about surveillance and what is the goal of surveillance, but the main goal is to help you work on your prevention activities. So if you do the measures to prevent VAE, then the patients should have better outcomes. So this is the main goal. So first I'm going to talk about preventing VAE, and then I'm going to talk about preventing VAP. There's some overlap, but there's also some differences. And a very important thing to emphasize, which Dr. Park talked about this morning, is that VAE is not just infection. VAE is a new metric that captures all complications of mechanical ventilation, some of which are pneumonia, infection, but also there are some non-infectious complications of being on a ventilator. And one of the goals of changing to VAE was that we could try to reduce morbidity and mortality from being on a ventilator for all reasons, even if it's not infection related, okay? So the first part of this, which will be preventing VAE, we'll talk a lot about some of the strategies that prevent the non-infectious complications of mechanical ventilation. And then after that, I'll talk more specifically about pneumonia, okay? Okay, so as I said, the focus now is shifted away not just from infection prevention, but really from prevention of complications for patients on ventilators. And there are three major approaches to preventing VAE. So one is to avoid intubation. If you cannot put a patient on a ventilator to begin with, then they can never get VAE or VAP. So keeping the patients off the ventilators is a very important strategy. If you can use non-invasive ventilation strategies like BiPAP or CPAP or other things like that, then you can avoid the complications of ventilators. So that's the first strategy. The second strategy is minimize the duration of mechanical ventilation. So if you can keep the patient on the ventilator for only as short as is needed clinically, then the sooner you can get the patient off the ventilator, you can prevent VAP or VAE, because if when they come off the ventilator, they will no longer be at risk for ventilator complications. And then the third thing is targeting the specific conditions that cause VAE or trigger VAE, and I'll go through what those conditions are. One of them is pneumonia, but then there's also other things that cause VAE. So you want to target those things in preventing VAE. And for children, VAE might have different causes than adults, and it might have different causes based on which ICU type you're in. So for neonates in a NICU, neonatal ICU, the causes of VAE will be different than for older children who are in a pediatric ICU or than for children who are in a cardiac ICU. So there's some differences across different ICU types. Does that make sense? Okay. Oop. Okay, so just like Dr. Park showed you the circle of surveillance, there's also a circle for prevention, okay? So as when we think about VAE and how to prevent it, there's kind of multiple steps. The first step is intubation, like we talked about. If you can avoid intubation, then you'll never get a VAE or a VAP. So that's where you start. But once you get intubated, there is daily care that we give every day to patients on ventilators. And if you do that daily care in a certain way, which we'll talk about, you can prevent VAE or lower your VAE rate. And then every day you want to talk about can the patient come off the ventilator yet? And when will they be ready to be extubated? So that's an important part, is regularly thinking about, does this patient still need to be on the ventilator, and how can we get the patient off the ventilator as soon as possible? And then once you get the patient off the ventilator, you want to avoid re-intubation. So it's a balance. You want to take them off as soon as you can, but you don't want them to come off too early, because if they have to be re-intubated, that's also not good. So you thinking about when is the right time to remove the patient from the ventilator, and having a thoughtful discussion about it every day on rounds is a very important part of preventing VAE. Okay, so this is a chart from a published paper by Dr. Michael Klompus, who's one of the experts, the world's experts in preventing VAE, especially for adults. He works in Boston at the hospital next door to mine, the Brigham and Women's Hospital. And I'm going to spend a minute or two on this chart because I think it's very useful, okay? So this chart lists 6 different strategies or interventions you can use to prevent VAE. I'm going to talk about each one of these individually, but they include minimized sedation, paired what's called spontaneous awakening trials, or SAT, and spontaneous breathing trials, or SBT, early mobility, low tidal volume ventilation, conservative fluid management, and conservative transfusion thresholds. So these are all strategies that we'll be discussing to prevent VAE. These strategies have, there are studies that have shown what is the benefit of these strategies, and they help in different ways. Most of these strategies, if you follow them, can help you reduce the duration of mechanical ventilation. So if you follow these strategies that we're going to talk about, it can help patients get off the ventilator sooner. But in addition to that, it can also help reduce the 4 conditions that most commonly cause VAE. And you can see them listed at the top of this chart. So the 4 most common conditions that cause VAE are pneumonia, which is obviously what many of you are already doing surveillance for and thinking about very carefully. So that's one of the key conditions that cause VAE. But also atelectasis, collapse of the lung, can cause VAE. ARDS, respiratory distress syndrome, can cause VAE. And fluid overload in the patient can cause VAE if they receive too much fluid and they have fluid in the lungs. So all of these strategies that we're going to discuss can reduce all 4 of these conditions that cause VAE. And part of the reason to change from VAP surveillance to VAE surveillance in the United States was that we want to reduce all of these complications of patients on ventilators, not only pneumonia, which is only one of the 4. So these strategies can help reduce all of these complications, and they can help reduce the VAE rates. Does that make sense? Okay. So the first strategy for reducing VAE is minimized sedation. So we know that when you're on a ventilator, patients are receiving medications to keep them sedated. So if the sedation is too deep or is continued for too long, it can cause the patient to be on the ventilator for a prolonged amount of time. And studies have shown that if you have too much sedation or are sedated for too long, that it increases your risk for atelectasis, for collapse of the lung. It also increases the risk for aspiration, because if the patient is too deeply asleep, they can't prevent aspiration as well. And it also increases the risk that the patient cannot clear their own respiratory secretions, because you have to be a little bit awake and coughing, right, to help clear your secretions. So all of these can increase the risk for pneumonia. So, and we also know from studies that the medications we use for sedation for patients on ventilators, including benzodiazepines and opioids, these medications, receiving these medications is an independent risk factor for IVAC that you heard about this morning from Dr. Park. So for all of these reasons, if you can minimize sedation for patients on a ventilator, you can reduce the VAE rates and you can reduce complications from being on a ventilator. So this is one of the key strategies for preventing VAE, is to minimize sedation as much as possible. The patient, you still have to keep the patient comfortable on the ventilator, so there has to be some sedation, but you want to try to keep it to the minimum amount necessary in order for the patient to be comfortable on the ventilator. Okay, the next strategy for preventing VAE is to perform what's called daily coordinated spontaneous awakening trials, or SAT, and spontaneous breathing trials, or SBT. So this is a way to let the patient wake up a little bit and breathe even while they're still on the ventilator, okay? There are several studies that have been done looking at these kinds of awakening trials and breathing trials, and they were found to protect against VAE, to be associated with lower VAE rates. And patients who had these trials done had a shorter amount of time on the ventilator. They could be extubated between 1.5 and 2.5 days earlier if you did these spontaneous awakening trials and spontaneous breathing trials. So the goal of these trials is to minimize sedation. It goes together with what we just talked about in number 1. So less sedation means you can be more awake and you can breathe more on your own. So you get all the benefits that we just talked about. CDC has a collaborative going on called the Wake Up and Breathe Collaborative. It's a group of 12 ICUs that worked together to implement spontaneous awakening trials and spontaneous breathing trials for patients on ventilators. And they found that by working together on this as a key problem to tackle, they were able to increase the amount of SATs and SBTs that the patients were receiving every day. Up to about 75% of days on the ventilator, they were able to have spontaneous awakening and spontaneous breathing trials. And in this collaborative, they found that when they did that, when they increased the amount of awakening trials and breathing trials for the patient, the VAE rate went down from 9.7 to 5.2. And they also decreased the IVAC, the infection-related VAC events, from 3.5 to 0.52. And they also found that it decreased the length of stay in the ICU for the patients. So there's evidence that allowing patients to wake up and to try to breathe a little bit on the ventilator each day can reduce the complications from mechanical ventilators and can reduce VAC and VAE. So this is the second key strategy for preventing VAE. So you see that these first two, they're not really specific for pneumonia, right? They're more about just preventing all complications of being on the ventilator. The third strategy for preventing VAE relates to early mobility. So we know that if you are immobile while you're on a ventilator, it's a risk factor for a longer length of stay in the ICU, and it's also a risk factor for developing pneumonia and atelectasis, and also for delirium. So more and more ICUs in the United States are trying to mobilize patients while they're still on mechanical ventilators. Obviously, they still have to remain in bed while they're intubated on the ventilator, but if you can keep them awake enough to do a little bit of mobility, that can help. This one is a little bit challenging to implement because you still have to have the patient sedated enough to be safe on the ventilator, and you don't want them to pull out their tube if they're too awake. but this is something that people are working on. So it's very early in this early mobility implementation, but it can, if you can do it, it can help shorten the duration of ventilation and get the patient off the ventilator sooner, okay? The fourth one is about how we use the ventilator, the ventilation strategies. The goal is to use low tidal volume ventilation. So if you use low tidal volumes when you're on the ventilator, it's associated with lower mortality rates in patients with ARDS, and it can help prevent these complications of ventilation. It prevents atelectasis and pneumonia and ARDS. And there have been a lot of studies looking at this low tidal volume ventilation, we call it. And in adult patients, if you do it, it is associated with lower rates of lung injury and lower rates of pulmonary infection and atelectasis. And it also, again, is associated with decreased length of stay in the hospital and lower mortality rates. We don't really have good evidence for children on what is the perfect tidal volume ventilation to aim for, the goal, but we know that lower tidal volumes are associated with less lung injury. And for VAE, we're trying to prevent lung injury, not just pneumonia, but all injury to the lung when you're on a mechanical ventilator. The fifth strategy to prevent VAE is about fluid, conservative fluid management, and avoiding fluid overload. So we know that about 20 to 40% of VAEs are attributable, are related to fluid overload. Patients on ventilators often get a lot of fluid every day through the IV, and if there's too much fluid, it can cause congestive heart failure, it can cause pulmonary edema, fluid in the lungs, and it can cause effusions, pleural effusions. And so avoiding that fluid overload by being more conservative with your fluid management can help avoid those complications. And there's some high-risk time periods during a patient's care when they're on a ventilator where it's especially important to think about the fluid status and how much fluid they've received. And those two time periods include after resuscitation for sepsis. So when a patient comes in with sepsis, they have to get a lot of fluid initially to help support their blood pressure. But once they're stabilized in their blood pressure, then you don't want to keep giving them too much fluid because that can injure the lungs and can cause overload of fluid in the lungs, which can cause VAE and complications on the ventilator. The other time to think about the fluid status is when you're weaning the ventilator. You don't want to be giving too much fluid to patients who are weaning on the ventilator and getting close to being extubated because that can delay their extubation and cause them to remain on the ventilator for extra time. So when you're weaning the ventilator, you want to be conservative about your fluid and not give too much fluid that would cause fluid overload for the patient. That's one of the most common causes of ventilator-associated events is having too much fluid in the lungs, okay? Whoops. And then the sixth one is related to that, but it's conservative blood transfusion. So just the same way by giving too much fluid can cause overload in the lungs, if you give too much blood or blood products, it can also cause injury to the lungs for the same reason. And blood transfusions are associated with fluid in the lungs and ARDS and pneumonia also. So we need more research about this, but one strategy for preventing VAE is to only give blood transfusions when they're really necessary, not to give too many blood transfusions because if you overload the patient with too much blood, it can cause fluid overload and VAE and make it harder to get off the ventilator quickly. Okay? So all of these strategies that I've just mentioned relate to preventing all complications of mechanical ventilation, not just pneumonia or infection, okay? We'll talk in just a minute about some of the more specific things that we have traditionally done in the hospital to prevent infection. But by changing from VAP to VAE, one of the benefits is that we're working to prevent all complications of mechanical ventilation, not just infection, and that will help the patients because if you have a VAC or a VAE, that's associated with higher mortality and worse outcomes for patients. So if we can reduce all the complications of being on a ventilator, then we can reduce morbidity and mortality for the patients, even though some of these strategies are not just specific to infection, but they address all the complications of being on the ventilator. So as a reminder, the three major strategies: you want to avoid intubation if you can and try to use non-invasive ventilation. If you have to intubate a patient, you want to minimize the amount of time that they stay on the ventilator and try to get them extubated off the ventilator as soon as possible. And then while they're on the ventilator, you want to focus on these specific conditions that cause VAE by thinking about the amount of sedation, the amount of fluid, the amount of blood transfusions, and the low tidal volume ventilation. All of these practices can help you prevent VAE. Okay? A lot of the studies about this really come from adult patients. And for those of you who take care of children, we still need more research on what the best strategies are for children. But it's the same principle of trying to avoid these causes that make it worse for your lungs when you're on a ventilator. So maybe I'll just stop and ask some of you if you have any experience with any of these strategies in your hospital. In your intensive care units for patients who are on ventilators, do the doctors and nurses think about the fluid status and the blood transfusions and the sedation? Do they talk about that every day, and do they try to work on minimizing that? Does anyone want to volunteer to say if you know if any of your doctors or nurses are thinking about this in your intensive care units? Have any of you heard any of your doctors or nurses in the intensive care units talking about these strategies to decrease injury from being on a ventilator? Yeah, could you tell us a little bit?
Thank you. In our hospital, Persahabatan Hospital Indonesia, we actually do to minimize the fluid. So in our ICU unit, we always try to make the balance become 0 or negative. But about the the volume, the tidal volume, we haven't done that yet. Thank you.
Great. So we heard that there's always discussions about trying to make the fluid balance negative or at least equal, neutral. It's harder. Maybe you haven't heard quite as much about the low tidal volume ventilation. That's something that maybe the ICU doctors are talking about amongst themselves, but maybe they don't share it as much with everyone else and is a little more complicated. Anybody else have that experience, or do you know if your ICUs are thinking about the fluid and the sedation? Yeah. Oh, great.
I come from Vietnam. Yeah, related to infection related to cái mechanical ventilation in my hospital, City International Hospital, to prevent to prevent the ventilator associated infection. My nurse always put patient head in 30 degrees C. How about this in the patient position? Okay. I would like you to answer to me now.
Okay, good. I'm going to talk about that in just a minute, about elevating the head of the bed, but that's something that we have often done to prevent pneumonia. Yeah, good. Does anyone else want to share any experiences about what's happening in your ICUs?
I have one question. In children, we actually prefer to use the pressure control ventilation. So the tidal volume is going to be very, what do you think about it?
That's a good question. So we don't really have much research yet about this. We need to do some studies to understand which ventilation strategies actually reduce VAE the most for children. But I think you're right. Sometimes it's controlled, and it may not be as much at the choice of the individual doctors. Yeah, so we need to learn more about that. Okay, good. So now I'm going to talk more specifically about VAP prevention. You'll see that there's some overlap, but I'll talk about some of the things that we do in Boston to work on preventing VAP. So if we could switch to the next slide set, which is the VAP bundle. Perfect. Thank you. Okay. So I'm going to tell you about, do you all know about bundles? Do you use bundles in your hospital? Bundles are sets of prevention strategies that you do together to prevent one problem. So for CLABSI, for example, for central line-associated bloodstream infections, we have a bundle of practices that if you implement them with high reliability, they can reduce bloodstream infection rates. And so we also have a bundle of strategies to prevent ventilator-associated pneumonia, or VAP, and I'll tell you about what is in our bundle at Boston Children's Hospital, and I'm going to go over some of the evidence behind the components of that prevention bundle for VAP, okay? Okay, this might be a little hard to read, but I just wanted to say that even before we changed to VAE, we've been working on preventing VAP for many years using the old definitions, and there's SHEA, the Society for Healthcare Epidemiology of America, put out a document about the strategies to prevent VAP. This was published in 2014. You can find this on the SHEA website if you go look online. But they had a set of basic practices that were recommended to implement in the hospital to prevent VAP. And it's the practices that I've circled in the red box. So I'll just read you what some of these practices are, because I know it's probably very small in your printed slides. So the first one is to use non-invasive positive pressure ventilation for selected populations. So again, this idea that if you can avoid being intubated, you can prevent VAP. The second one is assess readiness to extubate daily using spontaneous breathing trials. So just like we talked about, allowing the patient to breathe and then seeing if they're ready to be extubated. So even before we had VAE, this was a recommended practice to prevent VAP. The next one is avoid unplanned extubations, just like we talked about. So you don't want to have the patient extubate themselves too early or have the tube fall out because that can cause more injury to the lung. So all of these things were already recommendations even before we changed to VAE surveillance. And then there's a few that I'm going to talk about specifically that were not part of the VAE strategies that I just went over with you. So the next one is provide regular oral care, which is brushing the teeth and gums. So I'm going to tell you about the evidence for that and how we do that in Boston. The next one is elevate the head of the bed to 30 to 45 degrees. Can I just see a show of hands? How many of you elevate the head of the bed for patients on ventilators in your hospital? Okay, so some of you are doing this. So this has been recommended as a strategy for a while to prevent VAP, but you see the quality of evidence is low. So I'm going to talk about, there's not a lot of good studies showing that these interventions work that well, but I'll tell you about that. The next one is about change the ventilator circuits only if they're malfunctioning. So the idea is don't change the ventilator at regular intervals. You only change the ventilator if something malfunctions. Otherwise, you just keep the ventilator circuit the same and you don't mess around with it, okay? And then the last two are just about the types of tubes, endotracheal tubes you use, cuffed tubes, and then prevent condensate from reaching the patient. So these were all strategies that were already recommended to prevent ventilator-associated pneumonia, and this document was published, about 5 years ago, listing these as the core strategies for preventing VAP. This is the same thing, but this one is specific for neonates. So if you work in a children's hospital or you have a NICU in your hospital with premature babies, it's a lot of the same, it's basically all the same strategies. Sometimes there's more or less evidence for neonates than there are for older patients, but it's pretty much all the same things. Minimizing mechanical ventilation, minimizing sedation, doing oral care, all of the things that you've heard about. One difference for infants is that instead of brushing the teeth, since there are no teeth for babies, instead we wipe the gums with usually just sterile water and gauze instead of using a toothbrush and toothpaste. So that's one thing that's a little bit different for newborn babies compared to older patients once they have teeth. But otherwise, it's pretty much the same strategies, okay? Okay, so I showed you remember that chart with all the arrows? I showed you the conditions that most commonly cause VAE. And here you can see in this table what proportion of VAE are due to each of those causes. This is based on 4 different studies that looked at this. What were the causes of VAE? And you can see the first one is pneumonia and or aspiration. So if you look at the right, which is all the studies combined, it's estimated that about 36% of VAE is due to pneumonia. So we've spent a lot of time thinking about VAP in the past and how to prevent VAP, but remember that VAP only accounts for about 1/3 of all cases of VAE. So there's a lot of VAE that is not related to infection. And some of the patients where you are doing surveillance for VAP and you're identifying VAP, it's possible that those patients actually don't really have pneumonia, but they might have one of these other causes of VAE, because it's very hard for us to tell using the old definition who really has pneumonia or not, because as you heard, it's based on interpreting a chest x-ray or clinical signs which overlap with non-infectious causes. So that's why VAP is challenging. But pneumonia does cause about 1/3 of VAE, so it is an important thing to work on preventing. The next one is pulmonary edema, so this fluid overload. That accounts for about 28% of cases of VAE. So almost as many cases are caused by fluid overload as by pneumonia. They account for almost the same proportion of VAE cases. And then atelectasis is about 14% of cases of VAE, and ARDS is about 9%. And then everything else is much, much lower. So if you just focus on those 4 things, preventing pneumonia, preventing fluid overload, atelectasis, and ARDS, if you can work on improving prevention for those problems, then you will prevent a lot of VAE, and your patients will have better outcomes. They'll have lower mortality and lower morbidity. So this is where the focus is really directed, okay? So I go back to this table that I showed you before. If we just look at the column for pneumonia, which I circled with red at the top, you can see that all 6 of these strategies that we just went over for preventing VAE, there's evidence that they actually decrease pneumonia. The black bars are where there's higher quality evidence from studies that it probably really does reduce pneumonia. And the gray arrows show there's some possible evidence from studies, but those studies are a little bit lower quality. But you can see all 6 of these strategies probably do reduce pneumonia. So if you do all the things we just talked about, working on fluid overload and fluid status, working on getting off the ventilator quickly, all those kinds of things, those will reduce pneumonia and will reduce VAP, okay? So those core strategies should be things that you're thinking about as you're working on your prevention bundle. So I want to talk about the other ones that are more specific for VAP that many of us have done for many years in our hospitals, okay? The first one is elevating the head of the bed. So some of you mentioned that you do this at your hospital for patients on the ventilator. So we know that being flat, being supine, could be a risk factor for VAP because the secretions pool, right, in the back of the throat. And if you're lying flat, they pool and they can go down the endotracheal tube, right, and get into the lungs, which could cause pneumonia. So for that reason, people have studied elevating the head of the bed for patients on a ventilator to see what is the evidence that actually improves pneumonia and reduces it. There have been 3 randomized controlled trials to look at this, and they included about 337 patients altogether. And only one of those 3 trials showed that elevating the head of the bed actually caused a significant reduction in VAP. The other 2 studies did not show any reduction with elevating the head of the bed. So the data are not that great, actually. They're not the best evidence that elevating the head of the bed really always reduces VAP. But it's possible that it helps, because that one trial did actually show that it decreases VAP rates. And because there's really no cost, it's free to elevate the head of the bed. There's no resources, and there's minimal evidence of harm. It doesn't really harm the patient to have their head of the bed elevated. Because of that, and because of the possible benefit, there's really no urgency to stop doing that. Most of us are still doing that, even though the evidence isn't that strong, because it's something simple that is free to implement, and it might have some possible benefit. So we need more research about this, but I'll show you our bundle, but this is still part of our bundle for VAP prevention in Boston at our children's hospital, because it's something we've done for a long time, and it's just, there's no reason to stop doing it, really, okay? The other thing that I mentioned earlier is oral care, which is brushing the teeth and gums usually. In adults, there have been some studies looking at chlorhexidine, which is an antiseptic. Do any of you use chlorhexidine in the mouth for patients who are on ventilators? I see some nodding. So some hospitals do this as a way to decrease the amount of bacteria in the mouth for patients on a ventilator, with the idea that if the secretions have less bacteria and they get to the lungs, there might be less chance of pneumonia, right? So people have studied this, but it turned out in the studies that using chlorhexidine for oral care for patients on a ventilator is not associated with reduced ventilator days or reduced ICU length of stay or reduced mortality. So it doesn't seem to really provide the benefits for patients. And in fact, there's even some evidence that it might increase mortality if you use chlorhexidine in the mouth for patients on a ventilator. So probably doing that might lower the frequency of false positive VAP, just because you have colonization in your mouth and in the endotracheal tube with bacteria every time you're on a ventilator. And if you use chlorhexidine, you're less likely to find those bacteria on the culture. But since it doesn't really improve any of the real outcomes like mortality or length of stay or length of intubation, it's probably not really reducing VAP. Because if it was reducing real VAP, you would see some of those benefits in the patient outcomes. So there's not a lot of evidence for chlorhexidine for oral care. This is just one slide of a meta-analysis looking at oral care for intubated patients using chlorhexidine and whether it reduces pneumonia or not. And just to say that if you separate the studies into studies that were double-blinded versus not, so the study, just look at the double-blinded studies that were higher quality research studies, there was actually no effect of chlorhexidine on reducing VAP in the highest quality studies. So it probably is not something that should really be a core part of a VAP prevention bundle.